Okay. Good morning. Can you hear me?
Good morning, Miss.
Thank you. So, let's wait for a few more minutes. Actually, tomorrow we don't have class. Okay, so next week we will we'll schedule our tomorrow's replacement class. Okay, you can tell me any time on Tuesday. Is it available from 2 to 4?
Sorry, Miss. 2 to 4 on Tuesday we have class.
Your voice is breaking. Please come again.
2 to 4 on Tuesday we have class.
Oh, okay. Any other time available?
Unsure. Monday morning maybe.
Monday, which time? 2 to 4, is it available?
No.
Thursday, can I miss?
Thursday, I have class.
Thursday, 11 to 1, miss.
Wait a minute, I will check.
Yeah, but Thursday we have class also with Misses.
Thursday.
Oh, yeah.
What about Friday, ma? Friday?
What time?
Anytime. Friday, I am free.
You think 11 to 1, okay. I will go.
Yeah, okay. So Friday, 11 to 1. Okay.
Okay.
Just remind me on Thursday. Okay. Just sometimes if some other work comes, means I may forget. Okay. So okay, Friday 11 to 1, right?
Okay.
You can share it with your other students also, please. Okay. What about others, whether they join or what is their plan?
Last time and see. Miss, later can we go through about the assignment again? I opened it. I'm not sure what we need to do.
Nothing is actually it's theory component only. You have to write about what is the topic? What I uploaded? Elbow fractures. Just go with you can follow Caroline Kistner, the therapeutic exercise. This book once again. Okay, I already have this Kistner book. I shared in WhatsApp. You have for fractures, each and every fracture, there are plenty of informations. And other thing is, the final part I will tell you that references and journal articles related to your topic. That is, you need to search it in the Google Scholar or anything that related to any PubMed, any article related websites are there. You go and search and then collect evidences, collect recent articles related to your topic. Whatever the fracture is, what is the reason physiotherapy advancement? Sometimes they may compare any new two techniques like that. You can collect 5 or 6, whatever I mentioned, you can collect it in the last part, right? The references and journal articles related to your topic. You just go through the physiotherapy advancement. What are the research articles like a recent 5 years? Okay, that will always be need to collect the evidences. Nowadays we are not you don't have that habit of developing the evidences, right? So nowadays we are following evidence-based practice. Evidence-based practice means you are for each and every condition and each and every treatment, how much the article is supporting, how much the journals are supporting, that is very important. Nowadays we are giving more importance to this type of journals. So you need to search for whatever condition topic I have given you. You need to collect the recent research work on that topic. Okay, that is very important. And management and assessment, everything is when you in this fracture topic in the Caroline Kistner or John Ebenezer, you may get lots of information related to assessment, management, and the mechanism of injury. Everything is all types of fractures, the same pattern. Incidents, we all know how much more common that type of fracture. That is one important thing. And then the cause and etiology, mechanism of injury of that specific fractures. Very common means, for example, I'm telling you shoulder fracture. Shoulder fracture is there means you can have numerous patterns. The patterns of injury would be there. That is what we call mechanism of injury. Like that, you can collect it. And then complications. Whenever you go through that in the Caroline Kistner, once again. Yes. So exercise intervention by body region. In this area only, you can get lots of information related to your topic. For example, if it is shoulder and shoulder girdle, just take for example, if it is a shoulder fracture means, just go to 481. Yes, from 481, you can have all the management, all conditions and all management. So here you can see that the management of shoulder disorders and surgery. In this thing, yes. So this one, the painful shoulder syndrome. In this thing only, they talk about the fracture and other important informations related to shoulder joint fracture. So you can get like that. For elbow fractures, you have one component called like that. You can go and collect the information or go through the internet also. You can get lots of information related to what is the assessment for the typical fracture. Okay, what are the management for that? Maybe POP application, when we have to apply POP, that is plaster cast, or when you have to apply surgical corrections, like open reduction and internal fixation, or sometimes you need to do external fixations. Like that, you will get lots of information. That's what I required. Okay, all the informations and all the important details related to the typical fracture. Okay. So already we have completed the upper limb mobilization, right? This thing. So the last week we have talked about the shoulder joint mobilization, elbow, and then the proximal radioulnar joint, and then distal radioulnar joint and wrist and metacarpal IP, all the joint, how we need to mobilize, right? So accordingly, you need to choose everything. You already know that for different grades and different amplitude, different ranges where you have to apply, and all the details and this theoretical concept should be matched with patient's condition. Okay, so after assessment only you come to know whether what technique you have to do, or what stage you have to progress. Everything can be decided by assessment. So just learn the knowledge, learn the concepts, learn the techniques, and then we after assessment only we can adjust it, or if you want to manipulate it, everything can be managed to make it suitable for patients. Each and every patient is different. Okay, their anatomy, their pathology, and the pain tolerance, everything can be varied. Okay, so according to that patient situation, you have to alter that. And one more thing is the complaints, the chief complaints will decide which way you have to proceed with this joint mobilization. I'm just giving you some clinical tips. That's it. We are not going into the lower limb joint mobilization. So the patients, the main complaint is maybe pain. The pain is severe means you need to switch on to different joint mobilization. Or if it is a stiffness, the stiffness is the most the prominent one, and they don't have pain, then we consider as a different group and treat it accordingly. Or sometimes they have equal the complaints, like both pain would be there and joint stiffness. So in that category, you have to, in the initial 2 to 3 sessions, you have to reduce the pain and then go for improving stiffness correction. Okay, so like that we can. And one more thing is, we already know accessory movement. What is accessory movement? Glide, rolling, right? So this kind of things are accessory movement, as well as we have physiological movements. So the physiological movement means normal flexion, extension, whatever it is. So whenever the pain is subsided, the pain is not that severe, means you can go for the same grades, that is grade 1, grade 2, grade 3, grade 4 on physiological movements. Do you understand what I'm saying? So accessory movements means it is for pain. During pain, severe pain or severe muscle spasm is there, means if you mobilize the whole thing, the soft tissues are also get involved. So it may produce severe pain. Okay, so what I prefer is whenever the pain is severe, means you go for accessory grades, accessory joint mobilization. That is this kind of anterior glide, posterior glide and all. If it is like more of painless and then more stiff kind of thing, more stiffness is there, means go for physiological movements in the grades. That is shoulder abduction is restricted, means do the movement, actually do the movement, and in that thing you have to go for grades. The grade 1 means in the initial 10 to 20 degrees. That is what the grade 1, that is small amplitude fast oscillations. Or if it is like if we want to go for grade 2, means you have to do 30 to 90. 30 to 90 and above is considered as grade 2. That is large amplitude and slow smooth movements. You can go for that. Or grade 3 means maybe 80, abduction 80 to 110. So like that you can decide. Whenever you meet the patient, then only you come to know what I am saying. Okay, so stiffness is a prominent thing and pain is not that severe, means you can combine it, both accessory and physiological, and more importance you can give for physiological movements. That will improve it. And this one, the pain is there, means always stick on with that accessory movements. Later on, after the pain is getting subsided or the active range is improved a lot, then you can go for physiological movements. Do you understand what I'm saying? Glide and slide, that's what we are seeing. The physiological movements means we already know the movement pattern. Abduction means you are moving your limb away from your body. In that thing, that 0 to 180 degree, you have to divide it into grade 1, grade 2, grade 3, grade 4. Grade 1 means in the initial first few degrees, first 10 to 20 degrees means that is what grade 1. And then if you are going for large amplitude, that is 90 plus. Now, if you are crossing 90 degree abduction to 110 from 30 degrees of abduction, then we call it grade 2. And then grade 3 means maybe 80, abduction 80 to almost to the end range, but we are not crossing that, you are not completing the movement. That is what grade 3. Grade 4 is the last degrees. That is your arm is by the ears, it is close to the ears, and that small amplitude ranges, right? That is 170 to 180. You have to do small amplitude to and fro oscillations. Then we call it grade 4. Okay, so like that, pain is there means always go for accessory movements. And if it is a stiffness is the severe one, then go for this physiological. More importance you have to give for physiological movements. Okay, just for understanding purpose, I'm telling you, because you may get confused with this so many terminologies: accessory movement, physiological movements, everything. So the glide and rolling and this kind of things without any movements, without any joint, that is degree of movements, just you are doing glides, caudal glide, distal glide. So different types of glide means, then we call it accessory movements. So far we have seen in the upper limb complex, everything is accessory movements, and physiological movements we already know what is the movement pattern and all. Okay. So hip joint. So let's come to the very another important joint. It's more or less similar to shoulder joint. All the how to say, the joint anatomy and joint surfaces, little bit difference is there. It is like in the hip joint, it is more congruent, more fit together compared to shoulder joint. So in the hip joint, you can see that the resting position, the important thing is in the initial treatment, and to reduce pain and to check the mobility, it's a safe that you choose resting position. So resting position is hip flexion 30 degree, abduction 30 degree, and slight extension. Just remember, we don't have any other option. You need to memorize this thing. Sometimes when you practice it, it becomes easy for us. Otherwise, you just remember this: hip flexion 30, abduction 30, and slight external rotation. Okay, and then one more thing is fixate the proximal segment, stabilizing and fixating the pelvis. So you one segment, that is the proximal segment, should be stabilized. So either if you have any assistance, you can fixate their pelvis, or sometimes you can use belts, or if you are strong enough compared to patient means, you can use one hand for stabilization. And treatment plane, we already know whatever the concave surfaces, that is the treatment plane. So here also the acetabulum, the line of the treatment plane is in line with the direction of acetabulum. Okay, so the another easy thing is everything is more or less same like shoulder joint. Okay, here hip distraction, or this is more of it's not a distraction, this is traction. We call it traction. So the limb is pulled in the long axis of the body, right? So we call it traction. It is not distraction, it is a traction. So indications, we already know for the first thing, what we are doing, this kind of traction and distractions can be useful for testing the mobility, how easy it is there. If it is stiffness or adhesion is there means, you cannot get that, you cannot distract, or you cannot go for traction to the joint. Okay, and then initial treatment, pain control, and general mobility, we can use this indication. These are the indications for joint traction. And the supine, with the hip in resting position, that is abduction 30-degree, flexion 30-degree, and slight external rotation. External rotation means your foot is facing little outward. That's what we call it. Okay. So just give a gentle traction. Don't give too much force, because the first time if you are doing means you don't know the condition of the thing, right? So just give the mild traction and then check the response. So it is like bed, the leg in the couch. You need to stand on the side of the leg of the patient, and then if you want, you can use this also. So belt can be used and wind around your pelvis. Okay, and then it cross the belt over the patient's foot and around the ankle. So it will assist you. That is the thing. Otherwise, without that belt also you can do. But if you are using your trunk, means it's more economical compared to the pulling the whole limb. It is helpful for you. That's what we are using our trunk to cause the traction. And both hands should be overlapped on the proximal malleoli. Okay, so this way you need to wrap your fingers and your hand around the ankle. That is, it should cover the both malleoli. What the thing. That's what without belt also you can do, but it is more of a tough job for us. Otherwise, if you use belt on your body, and if it is using that force, can be little easy. I will discuss it after all the details. We will see this. Okay, so the first one is traction. Okay, you need to understand that hip joint traction is there. So hip joint traction, and then the posterior, like same way in the shoulder joint we have seen the posterior glide, and then anterior glide. Okay, and then lateral distraction. Okay, so anterior glide, posterior glide, lateral distraction, and then traction. Okay, so the same way the convex is moving means the roll and glide are in the opposite direction. The posterior glide is useful for increasing flexion and internal rotation. So always maintain the hip joint in resting position. That is hip flexion to 30-degree, abduction to 30-degree, and then slight external rotation. And then because for lower limb, most of the cases you need to use belts. This assistive belts can be used to make it easy for us. That's what. Other than that, because if you are using your trunk, means it makes it easy, so easy for us. Otherwise, you need to hold the whole lower limb weight. The patient's whole lower limb should be carried by us. But to prevent that, you can use this kind of belts. Okay, so supine, the patient should be in the supine and then the resting position. That's what we call. And then if you have belt, no need to do this way. Otherwise, ask the patient to flex the hip and knee on the uninvolved side. Maybe if you are doing for left side, means right side hip and knee should be flexed. Okay. So this way you can stabilize without any help or without any belt usage, means we can use this way also. So at the first few days or first 1 to 2 days of consultation, if you always start with resting position. Okay, after that, if pain subsides and the stiffness is reduced, means you can go for the end ranges, whatever it is available. Okay, and then the therapist position and hand placement, we all know he's standing facing the hip joint from medial side. Okay, so in between the patient's leg, you need to stand and belt around your shoulder and under patient's thigh. That's why I told you to hold the weight of the lower extremity, we are using this belts. So one hand you can use for like a distal hand. Distal hand means that is far from the patient's body. This is what your distal hand, right? That should hold the distal thigh. Distal thigh. So in addition to that, it gives more support and more confidence to the patient. Maybe sometimes the belt may impinge on the important vascular structures. So to prevent that, you can place your hand on the area where your belt is located. And then the proximal hand on the anterior surface of the proximal, because we are always posterior glide means pushing, right? Pushing kind of action will help. So place your hand on the anterior surface of the proximal thigh and just push it posteriorly. So the mobilizing force should be given like for lower limbs. Just remember that for lower limb, don't ever use the forces from your upper limb. It may tiring, and then you can see 1 or 2 patients. After that, you need to take rest. We don't want that. So always the movement should come from your body or your trunk. So the mobilizing forces, like when we can get the more forces from your trunk, means if your elbow is extended, if you are extending your elbow, then it will shift directly to the patient's body. If you are flexed it or too much of flexion, means you are producing the force from your upper limb muscles. When you flex your elbows, then it is 100% it comes from your upper limb muscles. Okay, we don't want that. So always extend it. Extend your elbows. That is the main criteria for giving or producing movements from your trunk. Okay. And then one more thing is, if you want, you can adjust the couch, or otherwise you can flex your knees. Okay. Okay, that's it. This is what our hip posterior glide. Mostly to increase flexion and to increase internal rotation, we can use this posterior glide. But the problem is, most commonly the flexion would be easy. The flexion is more convenient or pain-free position. So the patient, what they adopt is they maintain it in flexion. So what is the restriction means extension. So always it is useful that anterior glide. The anterior glide is more commonly used in hip joint compared to posterior glide. That's why the flexion is already maintained. The patient can maintain by himself, because that is painless compared to all the convenient positions. Like in the during our before birth, our position normally is flexion. We all make it to the flexion of our whole body. That's why whenever it's convenient for us to maintain it in flexion, compared to extension. So we give more importance to anterior glide. Okay, so this is indications or to increase extension, to increase external rotation. These are the main problems. Whenever you handle the patient, you can come across this, like the extension is very difficult. So limping, the pain, because of pain or stiffness, the patient may limp. Like you can easily find out. To correct it, we need to give these anterior glides. Thereby, the extension is possible, and we can make it little smooth. The gait may be corrected easily if you follow this hip anterior glide. Okay, so the patient position is like we already you all see the picture, right? So it is prone lying, and it's not actually full prone lying. Half of their body, that is lower half, is hanging on this out. Okay, hanging it out, and then you need to stabilize by one leg should be placed on the ground. But this is, I feel mostly we don't find it very comfortable, right? If it is a young age or sports person and all, okay. Otherwise, you need to do it in sideline. Sideline is convenient for us. So the prone with the trunk resting on the table, and hip from hip joint, it lies outside. Okay, you need to know the level of lying on the couch. And then the opposite foot is on the floor. Okay, they need to place it, and if needed, they can weight bear also. Otherwise, just holding is enough. And here also the stand on the medial side of the patient thigh, and the same way you need to carry a belt to support the weight of the leg, and then with your distal hand hold the patient's leg the same way that you can hold it. Okay, hold it in this, because here it is not that vascular structures are there is no sensitive structures, so you can just hold the leg. Okay, if it is a posterior aspect only, you can expect a lot of vascular structures. That's why you are placing your hand under that area. But here it is more like muscles, only bony component, right? So that's why we can freely use the belt without any supports or without your hand placement. You can just use it. And then the distal hand should hold the patient's leg, and then the proximal hand is on the proximal thigh, just below the gluteal region. So this is the area where you have to give anterior glide. Okay, side lying. Side lying means you don't need to position like this. The whole body is flat on the couch. Okay, that is how to say. It is not like hanging freely on the outside of couch. It is not like that. In the side lying, you can make them on the any one side. That is, the upper side should be the treatable one. For example, if it is the patient has right side problem, means he has to place with left side lying. Okay, left side lying, and the right side should be the uppermost. Okay, and then you can give the same glide, but more of posterior to anterior direction. What I'm saying is, the patient is in the side lying, and then you need to stand here, and you need to give pose in this way. Same way, the standing position, everything for therapist is same, but the patient is little bit in side lying position. I think you all understand what I'm saying. Okay, so mobilizing force should be, I already told you, always extend your elbow, and then whenever we mobilize or whenever we do movements, that time the flexing the knee will help in giving more force compared to extended one. That is also in the stepping stance. Stepping means one leg is in front of the other, and then just flexing the knee is helpful for producing the movement. Okay, that's it for anterior glide. Now we will see the video on different types of glides and distractions. And one more important thing is this one, joint distraction. I already told you joint distraction and traction is different. So this is traction, and now what we are seeing is distraction. Distraction means you are increasing the space between the joint surface, but traction means you are pulling it on the long axis. The bone is pulled downward. It is somewhat called as caudal glide. Sometimes the confusion would be there. Just make sure that the lateral distraction means you are pulling it outward or laterally. That's what we call it, lateral distraction. And traction is pulling it on the long axis of the bone. Okay, this too is having confusion, but more important is this one, lateral distraction of hip. Just watch it.
Okay, we're going to perform lateral distraction of the right hip. Before we do it, we go ahead and we get a belt, and we're strapping the patient down right across ASIS. We don't want to have it above into the
So
abdomen or above.
you can see that this ASIS, on the level of ASIS, you can use the pelvis. Okay.
Right hip. Before we do it, we go ahead and we get a belt, and we're strapping the patient down right across ASIS. We don't want to have it above into the abdomen or above the iliac crest, and not too low. So I basically go right across ASIS, goes around the table, keep the patient as close to this side you're working on as possible. From this position, we're going to move.
Always ask them to be by the side of the couch. Thereby, it's easy for us to give mobilization, and then you can avoid trunk flexion or straining your back. Okay, always make them come to the edge of the couch.
Move, and we're going to use a mobilization belt that we're going to strap around the clinician as well as the patient's leg. I go ahead and get him in position. I'm going to put it around the patient's leg. And at this point, I'm going to strap the belt around my buttock, not onto my spine. And I'm going to bring the patient up.
Always make sure that it should be on the lowermost, or it will be it crosses your buttocks. Okay, then only it won't stay in your sacrum. Okay, that is very important.
So that his hip is about 60 degrees. We also want to take and put 1 foot forward and 1 foot back. My hands in this position, 1 foot's forward and 1's back. He's at about 60 degrees of hip flexion. My hands are going to actually go into the inseam, into the groin.
So the very sensitive areas, if it is very neurovascular structures are high, means in that areas, don't allow your belt to be in that place. Instead of, your hand should be placed. Okay, for example, this groin area where you have very sensitive, so many ligaments and arteries would be there. So always place it there, whenever if your belt crosses the distal thigh also, this aspect also, your hand should be placed in between.
And the belt is around my hand, so I'm not cutting into the patient. And also my line of force is going to be in this direction. I'm not coming completely lateral. Don't forget that you have an angle of inclination of about 125 degrees at the femur. So you're going to come off on about a 50 to 55 degree angle from this patient. And we're going to do a distracting force.
Can you see the resting position? So it's not actually resting, a little bit higher. So he's going maybe second day or third day, like that. Then only they can go for pain limiting range or stiffness limiting range. They will go. The first day means always use hip abduction 30-degree, flexion 30-degree, and slight external rotation. And after that, if you are progressing, means maybe you can go for other ranges.
From this position, I'm secured, and all I'm doing is distracting and pulling back, very gently leaning back, shifting my weight from my front leg to my back leg. Lateral distraction of the hip.
It's very important technique for hip osteoarthritis or hip arthritic problems and all. We can widely use this.
Okay, we're going to perform lateral abdomen or above the iliac crest, and not too low. So I basically go right across ASIS, goes around the table, keep the patient as close to this side you're working on as possible. From this position, we're going to move and we're going to use a mobilization belt that we're going to strap around the clinician as well as the patient's leg. I go ahead and get him in position. I'm going to put it around the patient's leg. And at this point, I'm going to strap the belt around my buttock, not onto my spine. And I'm going to bring the patient up so that his hip is about 60 degrees. We also want to take and put 1 foot forward and 1 foot back. My hands in this position, 1 foot's forward and 1's back. He's at about 60 degrees of hip flexion. My hands are going to actually go into the inseam, into the groin, and the belt is around my hand, so I'm not cutting into the patient. And also my line of force is going to be in this direction. I'm not coming completely lateral. Don't forget that you have an angle of inclination of about 125 degrees at the femur. So you're going to come off on about a 50 to 55 degree angle from.
So it is not purely lateral distraction, is somewhat facing is superiorly also. You should tilt sideways in a slight way that you can see the patient's face also. Okay. Not only it's purely lateral distraction, somewhat superior. Can you see the angle this way? It is not purely lateral. So it is this way. Is it clear? It's not lateral distraction, somewhat superior. But in the initial stages, you won't be that precise. Just give lateral distraction also. But after that, you can progress it.
This patient, and we're going to do a distracting force. So from this position, I'm secured, and all I'm doing is distracting and pulling back, very gently leaning back, shifting my weight from my front leg to my back leg. Lateral distraction of the hip.
This is a long axis traction or long axis distraction.
At the hip joint, okay? This is actually a technique that you can use if a person having sacroiliac or even like lower lumbar level pain and dysfunction, because sometimes when you give the thrust, again, it's not going to be localized just to the hip, but I'm going to be treating it shear effect on the unit.
You can use both legs also. Sometimes for lumbar traction, you can use this technique. So holding the both legs, and if you're pulling it downward, then it will cause lumbar traction also. It relieves the back pain. But here our main role is hip joint traction. Right.
It's definitely possible. This is one you definitely want a high-low table for yourself. Okay. What position do we think the hip should be in when I do the thrust? The long axis thrust. Right. So, right. So the open pack position for the hip, right? hand contacts are just proximal to the malleoli, okay, at the ankle, I can start to get a sense of where is his open pack position, where does it seem to move the most, okay, so I can take, start to just get an assessment of it. What kind of conditions might this be indicated in individuals with what? Huh? OA? Okay, arthritis, hip arthritis, what else? Piriformis syndrome, gluteus minimus tendinopathy, trophic bursitis. Hip impingement, yes. I'm thinking one I probably would not is if if there's a, I don't know, yes or no. I'm questioning a known labral tear. If they have a known labral tear, and then you're imparting this quick movement on where the joint is unstable. Impingement syndrome, that's happening to them because when they get that full flex, they're impinged up, so they're not in that position at all. So I might be able to reduce a lot of that muscle guarded exertion. So those are different conditions, but impairments you might find individuals with low back pain who have a lot of iliac psoas guarding as part of their impairment. This can be a really good technique to downstream those muscles. Reduce that guarding. So the person's just on the table, they take a deep breath in, as they let it out, I take up the slack, and at the end they just give the quick thrust, okay? As far as your position, very important, you don't want your feet side by side, you don't want them together. If I'm in partner forward this way, I want my feet in that line of movement, because that's the way I'm shifting my body, okay? You don't want to think so much pulling with your arms as much as it's more of a body movement, okay? So one time, just take a nice deep breath in for me, let it out. I can take up the slack, and then just when it's out, just give it a quick breath, okay? If I'm really interested in trying to, because I'm really trying to get to the lumbar spine, I might pull a little bit harder, but just keep out, hard. Under control.
If you want to target the joint or the low back, would you put them in the closed position?
No, and in fact, that's probably one of the you never do a thrust in the closed position, just like you want to do that. But you go, even when I try to focus my force on the hips, that you're going to have that effect of it's going to happen. In fact, I had thrown out my back one time. I went to that work for me that day. I was so guarding. We couldn't even get me to the other one. Yeah, so let me try this and pull it in the phone.
Now we're going to move into some posterior glides of the femoacetabular joint. We're going to do this through a progression. I'm going to start off in really a neutral position for the hip, and then I'll progressively move her into more range of motion, specifically into flexion. So as I start off, I can do a little bit of a log roll to identify her greater trochanter, and then I'm going to move my hand just slightly superior and medial to that position. If I want, I can do a slight skin lock over the front of that, and then my force is going to be downward and just slightly lateral. And then as I start to free up motion in the flexion, I can start progressing her. So I can move her up into a position where she's at roughly 45 degrees, and I can provide just a neutral mobilization. Some things to keep in mind when I do this version is that I am going to the patella with my current hand placement. And also, as I press, she's going to do a slight bit of lateral flexion of the spine, of which can aggravate some of your patients who might have concurrent low back pain. So do make sure that you're not just asking about a stretch sensation in the posterior aspect or in the gluteal region, but also if there are any other discomforts, including the anterior hip and lateral hip. Now, as I progress, I can move her into some more adduction, and again, just pushing in that direction that goes along the shank of the femur. To further the progression, then I can start to move into more and more flexion. I can start to add a little bit of rotation depending on where I feel that she has the most stiffness at. So now, if we take into account therapist parameters and
Can
patient
you see,
parameters.
there are, that's why I told you different ways we can try it, but it should match with the patient's condition. Okay, so initially he's do it by the side of the patient. That is, you can see the different progressions he is using.
And then as I start to
If it
free up
is too painful, you can do it like this. Okay.
motion and the flexion, I can start progressing her. So I can move. And then as I start to free up motion and flexion. And then as I start to free up motion and flexion, I can start progressing her. So I can move her up into a position where she's at roughly 45 degrees, and I can provide just a neutral mobilization. Some things to keep in mind when I do this version is that I am going through the patella with my current hand placement. And also, as I press, she's going to do a slight bit of lateral flexion of the spine, of which can aggravate some of your patients who might have concurrent low back pain. So do make sure that you're not just asking about a stretch sensation in the posterior aspect or in the gluteal
So
region.
if the person is having any other patellofemoral disorders, whenever you are compressing patella, that may be painful for some people. So you check with any other problem with low back and knee joint. So if it is nothing there, or if you rule out the problems, then you can go for freely, you can proceed with that. Otherwise, you need to give it in the distal thigh. Just avoid compressing on patella.
Also, if there are any other discomforts, including the anterior hip and lateral hip. Now, as I progress, I can move her into some more adduction. And again, just pushing in that direction along the shank of the
So you
femur.
can ask me when we need to do it on adduction. Means check the response, check the mobility on both adduction and abduction. If it's like adduction, it is more stiff compared to abduction, means go with adduction and do some posterior glides. Like that, it is decided by patient's condition. We can do some alterations or some differences you can do, but it is safe for them. It's applicable, as well as it doesn't cause any injury or other side effects.
To further the progression, then I can start to move into more and more flexion. I can start to
So I already discussed, right, that if the person is having any patellar disorders, patellofemoral disorders, means you cannot compress it, right? So what we can do is hold the patient's distal thigh. Okay, not from patella. You need to hold it on the distal aspect of the thigh and then give some glides. Instead of holding here, he need to hold or wrap their arms around distal thigh.
add a little bit of rotation depending on where I feel that she has the most stiffness at. So now, if we take into account therapist parameters and patient parameters, sometimes it's hard to reach across a patient. So in that case, I might want to be on the same side. This is literally the same technique. I'm just going on this side. It's actually kind of nice because now I can put my hands around that person's patella here, and then I push through my hands, not through the patella. And then my progression would be the same. Here I'm actually using my body contact as well as my hands to create that posterior glide. Arguably, you can get more force with this one, but it's completely up to you.
So if you want, in the posterior glide itself, you can add distraction also. So how in the first video we have seen, right, the lateral distraction, the belt should be to create some distraction. So you can combine that also. It is like more mobility and more improvement you can achieve. So along with this hip posterior glide, you can give parallelly, you can give some lateral distraction using the belts, right? So that is more effective. So like that you can add or change. So it's up to us to explore and find out which one is effective for them, which one is suitable. So always after applying the technique for 2 times, check the response, reassess it. Reassess like how you previously did the test. Okay. So whenever you do the first assessment, if you record it, means after all the techniques, repeat it or check it with the same assessment. like if you're check the hip flexion in standing means after application of techniques, go for the same standing flexion. Okay, don't measure it on supine lying. When you do first test, you do it in the standing, and then if you go check for like reassessment, if you're checking again, that time you check it in the prone lying or supine lying means it won't be that validate. It is not that correct or accurate. Okay.
You, what's comfortable for both your build as well as your patient's build. Now we're going to move.
So this is a way we have seen, right, in the technique, in the explanation of technique, we have seen this one.
A mobilization belt can help you brace the weight of the patient's leg and maintain good body mechanics. Position the patient with the hips near the end of the treatment table and have the patient stabilize the pelvis by holding the opposite thigh against his chest with his or her arms. Stand between the patient's legs facing the hip to be mobilized and place the mobilization belt around your shoulder and under the patient's thigh. Now position the hip in flexion with some abduction and apply the mobilizing force against the anterior thigh in the posterior direction. Bend your knees to maintain good body mechanics.
Okay, we're going to do an anterior glide of the hip, this right hip. And what I have to be careful with is you notice there's towels being positioned underneath ASIS on each side. I want to make sure that he's got space and he's got comfort and we're not crunching into the ASIS under the table. In this position, I'll bend his knee up and I'm just going to externally, internally rotate him so that I can better locate the greater trochanter. I don't want to be on the greater trochanter. I want to be on the head of the femur. So what we notice is if we find that location, the greater trochanter, the head of the femur is going to be about 125 degrees this way. So I want my hypothenar eminence to be on that position. Next, I'm going to take from this position and place my hand up underneath his knee, up onto the anterior side, so that his leg is staying on a level plane with the table. From this position, I come up and over, get up on top, get my elbow straight, and I do an anterior glide. Anterior glide on the head of the femur. Okay? This can help with external rotation as well as extension.
Okay. Next one is tibiofemoral articulation. The resting position is 25-degree flexion. Always start with 25-degree flexion of the knee joint. And the treatment plane is on the concave surface. That is the tibial plateaus. And then you can stabilize it with the femur. Mostly you in the initial stages follow that the proximal segment is stabilized. And then the tibiofemoral distractions, that is a long axis traction. You can give it in the supine lying, sitting, or prone lying. Okay, this is long axis traction. So if you want, one thing you need to remember is to improve the flexion, the last degrees of flexion, use internal rotation. Okay. And to increase the external rotation, to improve the end range extension, you can try external rotation. Okay, just remember it. For knee flexion, it is internal rotation. For knee extension, it is external. So always hold it around the malleoli, so around the wrist joint. Okay. So your both hands should touch the palmar aspect of your hand should touch the malleolus, lateral and medial. And then this one is posterior glide. And if it is knee flexed means okay. Otherwise, if you are sitting means the pad support should be given on the posterior aspect because it's a very sensitive structure where you can expect lots of nerves and vessels crossing that area. So always be cautious with that. So testing to increase flexion. So all the things. And if you are going like whatever you try, like after 5 or 10 times also, you are not improving means that maybe you can go for to increase flexion. It is you can combine medial rotation, right? So this one, medial or internal rotation at the end range. Medial or internal rotation means nothing but your foot is turned inward. Okay, that is internal rotation. External rotation is your foot is turned outward. So while doing the technique, you can add up this. So that's why you can see that it is turned inward. So either way, you can do this posterior glide, whichever is convenient, you can go for that. So comparatively, you can see that this is easy. Compared to this technique, that is maybe it is easy for patients, but it is more hectic and it's not that comfortable for us because we are bending it. So this is convenient. I feel in my point of view, this is very convenient. But you cannot give traction. Maybe if somebody is there, some other person is there means you can ask them to distract it and then you give the posterior glide. And extend your elbows, lean your body weight forward. This is tibiofemoral anterior glide. Either you can do this way or in this position itself, in the supine lying itself, you can apply some kind of hold it like the finger should be on the posterior aspect of the leg and then you can pull it forward. The same way you can apply in this direction. You can pull it towards you. Then it will be like it will be given as anterior glide. Either prone lying is not convenient means maybe go for the same position but give it in the pulling force. So you need to weigh the pros and cons, whether it is if you feel more uncomfortable but it is convenient for patient and it is too risky for them to be maintained in that prone lying or difficult position means maybe you can adjust, you can make some changes in your body alignment. Otherwise they are very comfortable. Engaged people means make sure that you are more comfortable. Okay, more easy for you to apply. Okay, like that you can according to the situation and circumstances we can change. Okay, maybe we will see them.
In this video, you are going to learn how to do arthrokinematic assessment and treatment for the dorsal capsule of the knee joint. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to PhysioTutors. The aim of roll glide assessment is to gain information on reactivity of the joint and of course articular problems such as capsular limitations. To To assess the dorsal capsule in severe limitations from 60 degrees of flexion to hyperextension, have your patient in prone position with his femur fixated on the table and the tibia and patella hanging freely. The other leg should be supported by a stool, for example. The condyles of the femur are the convex joint partner and the tibia is concave. So while moving the tibia, we have to roll and glide in the same direction. Now, induce a ventral roll with one hand above the patient's ankle and add the gliding component with your other hand on the patient's dorsal tibia into ventral and increasingly proximal direction perpendicular to the tibia. For end range limitations from around 0 degrees to hyperextension, there are two options. Have your patient in supine position with a sandbag under the proximal tibia of the leg to be examined. Grab onto the patient's distal tibia above the ankle with one hand from medially. This hand will induce a ventral roll into extension. Place your other hand on the patient's distal femur. This hand will glide the femur dorsally in relation to the tibia as the tibia is blocked by the sandbag. Then perform an equal roll and glide with both hands.
Okay, so this technique is different actually. This is like whenever you are moving the segment, that is the physiological movements are also combined, means we call it Mulligan's technique. Do you understand? So if the distal segment is moved along with the glides and rolling, then we call it the Mulligan technique. So just there is another version. I told you there are various schools for physiotherapy. So far, whatever we discussed, right, that is all Maitland's technique. And this one is a very exception. And you to find out the difference I showed you, this is like while gliding with this hand, the other distal hand is also given a movement, whatever the required movement, that is extension. During extension, you need to do that, or maybe ask the patient to do. And while doing the physiological movements, we are giving glides, right? That is what we call Mulligan's technique. So I don't want to confuse you with this. Okay, just leave this thing. This video we already seen, right? The first day itself, I explained this one.
I'll now demonstrate for you a posterior to anterior mobilization at the tibiofemoral joint. I will initially position my patient in supine. I'm going to come around and work on my patient's left leg. So I'm going to bring this leg up into a given range of motion that I'd like to perform the mobilization at. It's very key that you sit on your patient's foot so that way you can block any accessory motion that may be occurring. And what we want to do is we basically want to scoop up underneath the tibiofemoral joint. Here we're going to let our thumbs rest on the condyles of the femur, and we're going to apply a posterior to anterior force at the tibia. While applying pressure from my thumbs through the condyles, I'll be pulling towards me. This is stressing the posterior horn of the menisci and can be performed at various ranges of motion as an assessment technique. Now, it can also be utilized as what we'll refer to a scoop mobilization that can be targeted to treat posterior horn menisci derangement or issues of pain with deep flexion. Here, we're going to the point at the range of motion where the patient is first experiencing their pain, and we're providing the same technique through repeated motions, and afterwards we'll reassess for patient response.
Next, we're going to do posterior glide of the tibia on the femur.
This is like sitting. In sitting also, we can give the posterior and anterior glide.
I'm going to have the patient in a sitting position. I get her close to the edge as possible. This is going to help. We have a concavity on a convexity. So this would be for the patients having difficulty with flexion. So again, I'm going to find the joint line. I'm going to get as proximal to that joint line as I can, taking the ulnar side of my hand. I'm still on tibia. Here's the femur. There's the joint line. I get close to it. I'm going to put my thigh as a bracing mechanism right next to her. Also, my distal hand is right above the malleoli. From this position, I can do a distracting force, and I can do a posterior glide of the tibia on the femur. As she gains more and more flexion, if I need to get more.
So this is for distraction, and this hand is for giving posterior glide to increase knee flexion.
To it. I'm going to put my thigh as a bracing mechanism right next to her. Also, my distal hand is right above the malleoli. From this position, I can do a distracting force, and I can do a posterior glide of the tibia on the femur. As she gains more and more flexion, if I need to get more into that end range, I keep changing.
Can you see that he's increasing the range? After 2 or 3 sets, he may be improving, means go for the next barrier or next limiting range.
Do my distraction, and I do a posterior glide. Always staying in a dorsal or posterior glide as I'm going along that plane.
The posterior glide in this position, you can actually see that move a little bit. You see that? She has a little bit of joint play, right? Do we want some joint play? We want some joint play, especially when we're towards the open pack position. This is the open pack position. This is the closed pack position. So we're away from the closed pack position. So she should have some movement. But I place my thumbs on each side of the patellar tendon over the tibial plateau so that when I push down, I can feel the femur and I can feel the tibia and I can feel how much movement is taking place underneath my thumb. So I'm just reaching around the back side and pulling towards me for an anterior glide, pushing back towards her for a posterior glide. And I can feel, does that feel firm? Does that feel firm? And even though she's saying yes, it doesn't feel firm to me.
But is it pain or discomfort? There's a problem with the ACL?
They don't have nocioceptors, so
Okay.
not really going to feel pain. I just feel more laxity and infield. You get firm infield each direction with a little bit of laxity. Good. So that was your obvious bony landmarks and then the ligaments. Give those a try.
Hi, I'm Juan Gamble with Campbell University Physical Therapy, and today we're going to be talking about the posterior tibiofemoral glide to increase knee flexion. The two primary motions of this joint is knee flexion and extension. There are two main components of the joint complex involving the proximal tibia, which is a concave surface, and the distal femur, which involves two convex femoral condyles. So with knee flexion, we'll have it moving up, and because it is a concave moving on a convex, it will be rolling and sliding posteriorly. That's why when we have it down here, we'll be going in a posterior fashion to increase the knee flexion. To have the patient in optimal position, we'll have them supine, and we'll have the knee propped up at 25 degrees of loose pack, closed pack position, where most of the rolling and sliding occurs in the knee. So we would first want to stabilize the distal femur, and with the other hand, we're going to find the medial tibiofemoral joint line and wrap our hands around. From here, I will be putting force directly through the joint line in a posterior fashion. With the posterior tibiofemoral joint glide, depending on the grade and the magnitude of movement with the mobilization, we can do multiple things. I'm going to demonstrate for you the 4 different grades of the joint glide and what their uses are for. The first one we'll be going over is grade 1. Grade 1 involves slight distraction with small amplitudes at the beginning of the range of motion of the joint complex. Research has shown that this is effective for loosening up the joint at the beginning range of motion, as well as pain relief. So with the slight distraction, we bring the joint out, and then we will have small amplitude oscillations at the beginning of the range of motion. The second one we will show is grade 2. This involves slight distraction with large amplitudes through the middle range of the joint. This is a very important grade because it increases joint nutrition, it decreases pain, and it decreases swelling. So again, we will have distraction, get to the middle range of the joint, and then we will have large amplitude movements. The third one is grade 3. Grade 3 involves large amplitude movements through the middle to the normal range of the joint. Research has shown that this is effective for joint stiffness, as well as promoting joint nutrition in the joint. So again, we will have distraction. We will get to that mid to end range, and then we will have the large amplitude movements to increase knee flexion. The final one is grade 4. Grade 4 involves distraction again with small amplitudes at the end range of the joint. This is mainly used to decrease joint stiffness once we've already established full range of motion of the joint. So again, we will have distraction, posterior force to get it to the end range, and then small amplitudes to restore full range of motion in arthrokinematics of the joint. Okay, today I have Kristen as my simulated patient, and we're going to be going through the posterior tibiofemoral glide. So upon coming into the clinic today, she has complaints of a little bit of joint stiffness in her left knee. And when I took her through the examination, she was restricted in knee flexion. So I'm going to go ahead and prop her leg up on here. Okay. Are you comfortable, Kristen? Okay. So I'm going to take her leg into the 25 degrees of loose pack position. I'm going to go ahead and stabilize her at the distal beam. Are you comfortable? Yeah. Okay. If you have to feel anything, just let me know. So my other hand is going to come over here onto the medial aspect of the tibiofemoral joint. From here, I'm going to stabilize. I'm going to find that range. And I'm going to do, because she's having joint stiffness and a little bit of decreased range of motion, we're going to be doing grade 2 mobilization, which is the large amplitude through the mid-range of the joint. So go ahead and stabilize, grab, take it through. I'm going to go ahead and get to the mid-range again. I'm going to do a few. I'm going to go ahead and get to the mid-range again. I'm going to do a few oscillations. Research says to go ahead and do 10 to 15 oscillations 3 to 4 times, and then go ahead and recheck the joint. So after we would be done performing this, I would go ahead, take her through the range of motion to see if we gained anything. If we did have no increase in pain or increase in range of motion, then we might try a grade 3, possibly a grade 4 mobilization to increase the range of motion of the joint. I hope this video was useful to you today, and thank you for watching.
Okay, and you watch this after I send it. This video is also same, the anterior and posterior glide of knee joint. So either way you can choose it, but if it is like in the first day means go for resting position. After that, the end limiting range, you can choose the end limiting range. Okay, so the patellofemoral, sometimes the tibiofemoral joint has some impact or influenced by patella also. If there is any patellar restriction, that will also hinder the full range of flexion and extension. To avoid that, always check with the patellar movements, and if there is any problem with that, go for glides also, the patellar glide. So the proximal lateral glides, that is medial and lateral glides, and then superior and inferior glide, that is distal and proximal glides are there. So this is distal glide, that is you're pushing the patella downwards. Okay. So supine with knee extended, and then whatever the way. So this is resting position for patellar movements is full extension. Knee is extended and the pad support under the distal thigh. Okay, and then stand facing the patient's leg, and use your web space. Okay, that is that covers the proximal aspect of your patella. And if needed, you can use the other hand for some force protection also, you need that. And glide the patella in a caudal direction. So caudal, distal, inferior, everything is same. Okay. And medial and lateral glide. So here also supine with the knee extended, and if need, side lying is also used, and you can use it. So this is lateral glide, and if you're pushing towards you, then it is medial glide of the patella. So other hand is used under the thigh, the posterior aspect of the knee joint. So heel of your hand is used for pushing, right? So either you can, so somewhat what we can do is you can stand here on the lateral aspect and then use your heel to go for medial glide. Here for lateral glide, she's in the medial aspect of the patient's leg, and then she uses the heel to push. Okay, in the same way, you can turn this side, and that is, here you can see she's standing on the left side and using her heel, she's pushing laterally, right? So for a medial glide, what you can do is stand on the right side of, close to the right side of the patient, and place it in this way. Place the hands here, right? So cover the aspect and then give the heel force. Okay, heel force for medial glide. Simple, right? Okay, and then now we are coming to the proximal tibiofemoral articulation. Tibiofibular are useful for ankle joint movement. Ankle stiffness is there, means it is widely used for this ventral and posterior glides. So side lying, you can use side lying and pad support under the medial aspect of thigh. So always the top leg, the side in which you are going to treat should be on the topmost. And then you will slightly flex the knee so that it should be supported, fully support. Maybe if you want, you can use pillow also. If you don't get that, you can use towel support. But most important thing is place it on the medial aspect. Okay, and then stand behind the patient and placing one of your hands under the tibia to stabilize, and then you just give some outward force or pushing force. Okay, you can see here.
In this video, you are going to learn how to perform joint play assessment of the proximal tibiofibular joint.
get our very own assessment ebook and mobile app. Links are in the video description.
Hi, and welcome back to PhysioTutor. The aim of joint play assessment is to gain information on the reactivity of the joint and, of course, articular problems such as capsular limitations or, in this case, dispositions. Anecdotal evidence describes that in case of an inversion trauma, the distal fibula is pulled into ventral and distal direction by tension in the anterior talofibular ligament. This, in turn, leads to dorsal and distal disposition in the proximal tibiofibular joint, which can lead to decreased joint play and possible nociception next to limited dorsiflexion. To assess joint play of the tibiofibular joint, have your patient in supine or sitting position with the knee flexed to 70 degrees. The talocrural joint is brought into 10 degrees of plantar flexion and is fixated by the examiner. Then one hand fixates the proximal tibia from medially, and the other hand holds onto the head of the fibula with the thumb on the ventral side and the index and middle fingers on the dorsal side. Now perform a translation movement into dorsomedial and ventrolateral direction respectively, and compare the degree of translation with the other side. Then repeat the assessment with the talocrural joint in maximal dorsiflexion and plantar flexion. If there is no difference between the joint mobility in the maximal loose pec position compared to the maximal dorsiflexion position, and there is no joint play compared to the other side, it could indicate a reversible disposition of the proximal fibula. In order to treat this disposition, the proximal fibula is manipulated into ventral direction, which we will show you in another video. Okay. Hey, you've reached the end of.
Okay, today we're going to do the proximal fibula tib mobilization. We're going to take a dorsal or a posterior glide. What you got to be careful with is we're going to palpate, take the patient, put the patient in a about 80 to 90 degree bend. She's in supine. I find the fibular head, and I'm very cautious not to get onto the common peroneal nerve. So I'm going to use my thumb and my thenar eminence as a form of mobilization. I get down into this position, and I'm going to stabilize tibia, and I'm just going to do a very gentle posterior glide with fibula. Patient's in supine, she's relaxed, and I do this dorsal posterior glide. As you know, what takes place down at the ankle, when the ankle goes into dorsiflexion and plantar flexion, with dorsiflexion, we have movement because of the talus and the mortise going into and spreading the talar crural joint. It glides the fibular head in a proximal direction and also takes it into a posterior direction. So I might utilize this to help with dorsiflexion of the ankle. Then I'm going to.
So posterior glide is useful for dorsiflexion. If there is any loss of dorsiflexion movement, go and try for dorsal glide. Okay, that is pushing force. Okay, so that is useful for improving dorsiflexion. Just remember it. Dorsal glide in the proximal tibiofibular joint for useful for dorsiflexion. Okay.
Position the patient in a quadruped position, because conversely, with plantar flexion of the ankle, it helps to glide the patient ventrally as well as distally on the fibula on tibia. So she's going to get positioned into quadruped, and I'm going to make sure that her feet are kind of off the edge so that she's in a good position. I'm going to again palpate, find the fibular head. This part of my hand is going to get onto the fibular head, and I'm going to place my hand around the femur, or it can be on the tibia. I tend to grab the femur so that I'm not pushing and moving her. From this position, I want to be very careful, and I'm going to ask input from the patient. Does that feel comfortable to you? Yes. Or does that hurt? Because if I create any tingling or pain in there, I may want to go a little more in a distal direction, away from the head of that femur. So I'm always being conscious of the common peroneal nerve. This also will help, as we said, to enhance plantar flexion of the ankle, because with plantar flexion, we have a ventral glide of the fibular head as well as a distal glide of the fibula onto tip.
So if you to increase dorsiflexion, it's a dorsal glide, and to give to increase plantar flexion is ventral glide.
Okay.
And then now we are coming to these are all for ankle joint. For ankle joint mobilization only, you have to combine. How for knee joint, you have to do patellar mobilization. In the same way, for ankle joint, you need to go for both proximal and distal tibiofibular articulation. Okay, like how we do for distal and proximal radial ulnar. The same way for tibiofibular also, you have distal and proximal articulations. Okay, and the same, the technique, everything is the pad support and the placement of hands, therapist position and patient's position, everything is altered for different techniques. That's what we need to remember. And the technique, everything is same. The glide, posterior glide means you're thrusting backward, and anterior glide means it's moving forward. Okay, so this is for posterior glide. So the pressed against the fibula in an anterior direction when prone lying. So make them in quadruped also, okay. Like in the previous thing, either prone or quadruped, and then give ventral glide. And this is for like in the supine lying, it is for giving posterior glides. Okay, this is for posterior glide.
For distal tibulofibular joint mobilization, this intervention can be applied if hypomobility is felt after assessing the joint. The patient is lying supine on the table with the knee extended. The patient will find the distal portion of the fibula and will place their thenar eminence over this structure. The therapist will apply a posteriorly directed force at the appropriate mobilization grade, depending on the amount of hypomobility. This can be performed for 30 to 45 seconds for 3 bouts. This intervention will help improve dorsiflexion of the ankle, which can be assessed before and after the intervention to notice improvements. The patient can then be lying on their stomach with their knees straight. The PT will find the distal portion of the fibula and will place their thenar eminence over this structure. The therapist will apply an anterior force at the appropriate mobilization grade, depending on the amount of hypomobility. This intervention will help improve plantar flexion of the ankle.
Okay, so and then our ankle joint, very important. Most of the ankle fractures can lead to stiffness. So here we can see the joint surface, right? So the concave, the mortise, that is tibia and fibula, is like how wrist joint. In the wrist joint, the radius ulna form a concave structure, and then the carpal bones together form convex. Right here also, the concave mortise is articulates with the convex talus. So glides and roll are in the opposite direction. Okay, the convex is moving. So the convex is moving means the anterior glide for improving dorsiflexion and posterior glide for increasing plantar flexion. So the resting position is 10-degree plantar flexion, and the treatment plane is on the concave surface, that is the tibia and fibula. That alignment is a treatment plane. And tibia is tapped, or maybe you can hold it, grasp it tightly against the table. So supine, patient position is supine with the lower extremity extended. Okay, begin with the ankle in resting position and progress to the available range. Stand at the end of the table. So always leg in. Don't stand there, because the very distal aspect be coming to that. So always at the end of the table, and wrap the fingers of both hands over the dorsum of the patient's foot. Okay, so hold it very tightly. And then and one more thing is just distal to the mortis, that is joint line. Always just 2 fingers below your malleoli. Okay, that is what we come under mortis, the joint line. Okay, so here the thumb is placed on the foot region, that is the plantar aspect, right? The place your thumbs on the plantar surface of the foot to hold it in resting position. Okay, this is what we are going to do. Just pull it towards you. Okay, the belt is wrapped around the proximal aspect of the leg, and then some towel support under the posterior aspect of the distal leg, and then they place it in this way. Okay, just 2 fingers below your malleoli, you can come across the joint line. Okay, so this is the distal direction by leaning backward. Okay, so how we can mobilize means you need to move your body backward. And for anterior glides, okay, so posterior glide is for increasing the dorsiflexion, and anterior glide is for increasing the plantar flexion. Okay, so other things, all the practical things and all. So this is one. So posterior glide is for increasing the dorsiflexion. Okay, just move it towards the floor or towards the ground. Okay, that will improve the dorsiflexion. So this one. So prone lying, and then the same way. Prone lying means you need to push it downwards. Will increase the plantar flexion. Okay. So the anterior glide. Anterior glide is for plantar flexion. Just remember it. Anterior glide for plantar flexion and posterior glide for dorsiflexion. Okay. So we'll see the video.
A talocrural distraction manipulation can be very beneficial in increasing dorsiflexion range of motion for your patients. Position your patient supine on a plinth. We want the involved leg hanging off and the leg in a neutral position. We want to then grab hold of the ankle using a web space grip on both of our hands on the medial and lateral border of the foot. So again, we're grabbing just as so, using our pinkies to grip just distal to the talus and bringing the foot into dorsiflexion. We then want to use good body mechanics, lean backwards, and produce a distraction force. The manipulation force at end range is again a pure distraction moment. So we take them into end range distraction and manip.
So if you are using manipulation means that fast thrust, right? That is normally we don't do.
Is again a pure distraction moment. So we take them into end range distraction and manip.
Mostly we don't do that. If needed, we need to be have a thorough assessment, and we need to check the proper condition of the soft tissues. sometimes it has backfires. It can cause some ruptures and all. So always make sure that you do the sustained distraction. Don't go for high thrust manipulations. This is what manipulation is. Okay.
Same goals, to examine curl joint impairment, increase accessory motion, increase range of motion, decrease pain, improve periarticular muscle performance. Positioning, patients supine with good position over the edge of the treatment circle. Tailor curl joint is placed in the resting position or clinician at the foot of the treatment table facing the patient's foot. Stabilizing hand grips the posterior surface of the distal lower leg. Mobilizing, manipulating hand grips the talus anterior surface. Patient applies a grade 1 traction to the joint, stabilizing hand holds the distal lower leg in position, mobilizing, manipulating hand glides the talus in the posterior surface.
And you want to put them in a resting position. Stabilizing the distal tibia and fibula, and then gliding the talus posterior to facilitate dorsal.
Same goals, to examine curl joint impairment, increase accessory motion, increase range of motion, decrease pain, improve periarticular muscle performance. Positioning, patients supine with good position over the edge of the treatment table. Curl joint is placed in the resting position, or okay, you know that. Clinician at the foot of the treatment table facing the patient's foot. Stabilizing hand grips the posterior surface of the distal lower leg. Mobilizing, manipulating hand grips the talus anterior surface. Patient applies a grade 1 traction to the joint, stabilizing hand holds the distal lower leg in position, mobilizing, manipulating hand glides the talus in the posterior.
And you want to put them in a resting position. I'm stabilizing at the distal tibia and fibula, and then gliding the talus posterior.
This is for a dorsiflexion. Okay. Okay, ventral glide is for plantar flexion. And now we are coming to inversion eversion. Okay, so subtalar distraction is you have to give it in this way. Okay, for inversion, eversion kind of things, to improve that, for distraction, you have to give it like this. That is your proximal hand should stabilize the distal leg, and then you grasp the calcaneus and then pull it distally. Okay. So, and then to increase the supination and pronation, you need to give medial and lateral glide. Okay. So medial glide to increase the eversion. Okay. So medial glide means towards you, pull towards you is a medial glide that is useful for increasing the eversion, and lateral glide that is pushing it outward, that is to increase inversion. Okay, just you need to remember this, or you need to know the joint surface. What is the joint surface you are going to mobilize? So the either prone lying or side lying, whichever is convenient, you need to, and then the pad support or towel roll under the prominence site where it is impinging on the couch. And then elbow extended, always use extended elbows to give some kind of outward force or pulling force. Either way, you need to be like the elbow should be extended.
We're again working with the foot. In this position, what we're going to be mobilizing is the subtalar, and the calcaneus is going to be distracted from the talus. Calcaneus has the ability to work off of the subtalar joint. It can go into a varus motion, valgus motion. It can anteriorly glide, posteriorly glide, and it can also circumduct. We're going to do all these performances from this position. We have the patient lie into the supine position, get him comfortable, get him in neutral position with the ankle and foot. My stabilization hand is literally going to come around the fibula and tibia distal malleoli. And from this position, I'm going to take the calcaneus and I'm going to distract it from the talus. And I can do a lateral glide, a medial glide, I can circumduct it, I can anteriorly glide it, or I can take it into a posterior glide direction. The calcaneus has to have mobility in a multiple direction in order to function properly.
A medial to lateral glide at the subtalar joint can be used to increase inversion range of motion, as well as for pain relief and to mobilize soft tissues that have scarred down. So first we want to pre-position our patient in sideline, flex the top knee, and we want to grab our patient firmly at the talus. So we want to stabilize the talus in this position because we're mobilizing the calcaneus on the talus. So it's a subtalar joint mobilization. I want to grab firmly on the calcaneus. Leaning back, I'm going to use my web space grip. So I'm grabbing with my first digit as well as my second digit around the talus, providing a distraction and mobilizing using my right hand on that's located on the calcaneus.
Okay.
A medial to lateral.
So lateral glide. Sorry. Lateral glide to increase inversion and medial glide to increase eversion. So here he is going lateral glide. So that is useful for inversion.
Subtalar joint, so we don't have a huge concern about talar curl, plantar flexion, dorsiflexion, because we're doing subtalar. Subtalar neutral is the open pack position. So I'm not inverting or everting. Okay, so just kind of neutral position. Right. So so what I'm going to do now is when we just go down. Okay, so make sure that you're on the calcaneus proper, like not just like off of the fat pad or something like that. Okay, so my counter force here. Yes. If you want to reach underneath and grab here, it doesn't make a difference. Do whatever comfortable. Just stop it from moving laterally, right? So come here. I use, again, thenar eminence comes into the calcaneus. My counter force is here, locking it in, not at the same time, okay? So I pull with my right hand to lock it, take my left hand, and I'm going to push. Now notice I'm not trying to like rotate this, because remember, it's a translation, right? So if I'm here, and again, if you think about the way the subtalar joint is convex concave, so it needs to be not so much like trying to invoke some type of inversion eversion mechanism. You shouldn't really see the foot rotating much at all. It is just taking the heel and pushing it lateral. Okay, so my counter force is here. Here's my my force with my thenar eminence, and I'm pushing out. Okay, and again, you're not going to get like an appreciable motion with this.
So it's very difficult to go, oh, there's my grade 1, there's my grade 2. Like by actually wiggling like we saw in some of the joints, it shouldn't move much. So you got to go more kind of like internally thinking, okay, I'm pushing a little bit, grade 1, grade 2, grade 3, grade 4. But you're not going to get like, you can feel millimeters of displacement and try to figure out what you want before. Does that make sense? So are we going to get a lot of subscalar pain? So we're going to have to do a lot of grade 1s and 2s. I mean, not so much, right? Versus trying to free people up and get them some of those grade 4s. So I'm locked here. Thenar eminence comes to here, and I'm pushing again. My arm is straight, and I'm pushing laterally. So I'm pulling with my right, pushing with my left. Right? You can feel that. There's some pressure. Sound good? Yeah. All right. So another way we could do that. Sideline all the way. Okay. So we're here. This thing's out of my way. Okay. So whichever direction you want to go, and again, counter force here. So coming down to the heel, right arm pulls, left arm pushes, arms are straight. All my body's in alignment, long lever, and I'm pushing straight down from here. Sound good? Okay, so a couple different positions from there. You'll also see like here, they're just doing a little bit more of the knee bend to take a little bit shorter lever. Bottom, just doing kind of over a towel roll from there, but it's just pushing in the lateral direction. Okay, now Donald does it this way, sit on your butt. Off the edge. Instead of doing those, we'll actually come and do counter force here and here. So he'll actually kind of cup the lateral, or sorry, the lateral, right? Yeah, right? So he'll cup the medial aspect. So he'll push in here and then just kind of like do this with his arms. All right. So here's my counter force in my top arm, and my bottom arm is here. And then again, I'm getting my lateral glide. All it is pushing the calcaneus and the subtalar joint lateral. So you have options of doing this. So the one I just showed you is not pictured there, but I saw him do it. It's again a very viable way to it. Good. So whatever position.
Okay, so that's what whatever the convenience is the main thing. Convenient to you as well as convenient to patients is a basic one. So the thing is lateral glide. The remembering a point is which glide will use in which movements to promote or to improve which movement. That is the main category. That is the thing you need to remember. After that, the convenience, by the sake of convenience, you can change it according to the patient's necessity. Okay, that's it. I think we finished our mobilization. Okay, so I will send this thing, and if you want, you can see it, repeat it, and then check and practice it. Just observing or just watching the videos won't help you in during exam time. Okay, just practice it maybe once or twice. That is enough. Okay, if you have that kind of confidence, then it won't be a big problem. You can remember it never during practical exams and all. So that's it. We covered all the joints, all the important joints. Anything, any doubts, any clarifications? Okay, next week we will start the introduction to fractures and important things related to that. Okay, just practice it, and what glide, what is the use of that? Okay, and distraction and traction is different. That is what I want to tell you again and again. Traction means it's a long axis pull. Okay, but distraction is you're creating a space between the joint surface. Okay, so mostly how you can read it is like hip joint and shoulder joint, more or less same. Okay, in the same way, elbow and knee joint is also somewhat similar. And then ankle and wrist joint, the main joints I'm telling you. And some other thing added up details are there in your wrist joint, right? In the wrist joint, you can have like this convex scaphoid is fixed and concave is moving for increasing the flexion. Like that, you go through all the slides. It is helpful for you. And any doubts means feel free to ask me. And if you want, you can change the positions. It is not that you need to justify. That is important. Whatever position you are choosing, that should be like if they ask, maybe examiners may ask you why you choose this, whether it is convenient, means maybe you need to give good explanation. And it is approachable for applying technique. You don't strain yourself. You position the patient in such a way that maybe sometimes you may stress yourself. That is also we don't want. Okay. And one more thing is in your home, you can tell that the couch adjustment and these things are not available, so they can understand whatever your technique, whatever technique you are practicing. Just make sure that you are giving good glide, good stabilization, and proper pad support. Right, these things are very important. So if you don't have any doubts, we will wind up. And tomorrow we don't have class. That is on Friday. We have 11 to 1, right? Next week, Thursday, for tomorrow's replacement class, we will have it on Friday, 11 to 1. Okay.
Okay, miss.
Okay, ma. Happy weekend. Happy Diwali. Bye.
Happy Diwali to you, miss.
Thank you. Thank you, ma. Bye.
Happy miss. Bye.